So Nilay Aragon is our last speaker in this session from UNC.
Um, Thank you very much, Cynthia, for inviting me. I'm Nilay Tanık-Argon. I'm a professor in the Department of Statistics and Operations Research at UNC Chapel Hill. And today I'm going to be talking about a project of mine on data-driven decision-making in healthcare operations. Just to make clear from the very beginning, this talk is not going to be directly about machine learning, but it will have an indirect connection. And as a background, I'm an operations researcher, and my training is in industrial engineering. But as most of you know, there is a strong connection between operations research and machine learning. And so one of the obvious ones is that optimization, as most of you know, is in the heart of machine learning methods, like in support vector machines and random forest. It appears in the context of convex optimization or semi-definite programming and so on. And there are several colleagues of mine in our department that work on these problems. But the other relation, maybe that is lesser known, is that machine learning methods can be actually used very effectively in complex decision-making problems. And complex decision-making is is the main thing that we operations researchers do, in fact. So today I will be talking about a project where we are looking at this, we're using the second relation. And these complex decision-making problems can appear in many contexts. But I'm going to be focusing on healthcare domain. This is what I've been working, this is the main application that I've been working on for the past maybe 15 years. When you think of machine learning in the context of healthcare, I guess the first thing that comes to mind is like precision medicine, drug dosing or optimal interventions, optimal treatments, and so on. Another one that is gaining some speed in the last few years is use of machine learning methods in making decisions related to public health, like optimal interventions in certain situations that is of interest to public health, or preventive screenings, like how to do optimal preventing screenings for cancers and other diseases. And the third one, which I work on, is healthcare operations. So you can think of hospitals and clinics are like factories where certain operations take place, and machine learning can be very useful in this domain as well. So today I'm going to be talking about a healthcare operations project that I've been working on for the past few years with a research team in my department and also at UNC Health Care. It's about emergency departments. So if you've ever been to an emergency department or if you follow the news, you'll know that these are very crowded places where waiting times can be really long. And if you talk to a healthcare manager at the hospital or EDs, they will tell you that, well, we really want to minimize the shorten these waiting times, but our hands are tied. So these may cost a lot of money. So if you can find us solutions, that would be wonderful. Right, so we've been working with the UNC Chapel Hill, UNC hospitals at the Chapel Hill ED to find ways to improve their waiting times. So in order to understand the problem, I need to walk you through a little bit over this patient flow in an emergency department. So when you enter an emergency department, as most of us did in once or twice in our lifetime, the first person that you'll see is a triage nurse. So this triage nurse will ask you questions about your health and why you are there and take your vitals and so on, and will give you a score, an emergency severity score in terms of your criticality from 1 to 5, and then you'll be sent to a waiting room. Then when the time comes, then they're going to take you into an emergency department bed. So these squares that I put up there represent beds. And then, so at the emergency, when you're in a bed, what happens is you're going to talk to a nurse or a doctor, and then they'll start doing some tests on you and start the treatment maybe. And at some critical point during this process, the providers will make a decision whether you can go home, you're ready to go home to be discharged, or you need further treatment up at the main hospital or admitted to the hospital. Okay, so let's take a closer look at these patients who need to go to the main hospital. So here, what I call stage one of the time that a patient spends in the emergency department is ED workup. So this is where your treatment and tests are done. After that point in time, where the physician, I wish I have a so at this point in time, right between stage one and stage two, the physician makes a decision about to admit you or not and makes a call to the hospital, to the main hospital, and starts the process. This process can be really long because they need to find a proper ward for you. They need to find a proper team, care team for you up at the hospital, and then they need to prepare the bed and so on. And while this is going on, you as a patient will still stay at the emergency department and will occupy a bed. So that period of time where they are not treating you at the ED is called the boarding time. So you're boarding to the hospital, but you're still occupying an emergency department bed. So your total time at the ED will be stage one ED workup and stage two boarding time. Well, if you talk to anyone that runs an ED, they will say that these boarding times are killing them. So these can be really long, like hours, 2 hours on average at UNCED. And they want to find a solution to this because this is not value added time. Since you are, as a patient, blocking that bed, the waiting times at the emergency department will get longer and longer. So one solution to this that we talked about with emergency medicine physicians and nurses at UNC hospitals is, what if we can predict those who are going to be admitted right from the beginning at the triage stage. So some nurses are very optimistic about this. They say that, oh, I can really quickly tell whether a patient will be admitted or not. But just instead of relying on a nurse's experience, what we can do is better. We're collecting some data about this patient at the time that they enter the door, so we can use this data to predict whether this patient is going to be admitted or not. And if this prediction is really strong, is high, the probability of admission, then we can call, and the physician can call the hospital and reserve a bed right at the beginning of this process. So throughout my talk, I'm going to call this process of requesting a bed early at triage as bed request at triage, BIRT. And I'm going to use it as a word and as a verb. So what happens if we make this call early is that, now as you can see from this picture, previously it was stage one, then stage two. So now it's in parallel, stage one and stage two in parallel. So instead of taking the sum of these two, we're going to take the maximum of these two. And the waiting time, the total bed occupancy time for this patient is going to shorten, which is really nice, right? For that patient, it will be shorter. So BIRT is good because it reduces the length of stay for the birthed patient, for that patient in particular. But not just that, it indirectly reduces the waiting times of consecutive patients, because this patient who's going to go to the main hospital will vacate the bed earlier, and which means that you're going to push more patients into the emergency department faster. So this is a very simple concept from queuing theory. If you improve service times for previous patients, then as customers there, it's going to improve the waiting times for others. But if BIRT is this wonderful, why don't everybody implement this? Obviously, hospital management will not like false bed requests. Why? Because this is waste of their time and resources. For hospitals like UNC and Duke Hospital, they not only serve this Chapel Hill, Durham area, but they also have patients transferred from smaller community hospitals from all over North Carolina. So if you are working on a bed preparation for a patient from the ED, then the hospital may just deny access to a transfer patient. So it's waste of resources, and hospital management doesn't want to do that. Therefore, our goal in this project was to find a balance between these advantages and disadvantages of BIRT. And what we needed to implement BIRT is first, we need a good tool that to estimate the probability of hospital admission at triage. So this is where statistical techniques or machine learning techniques come into play. Then the second one is once you have the probability of admission to the hospital, then what are we going to do with this number? If, say, for a patient, it's 75% probability that this patient is going to be admitted. Is it high enough? Or should I also look at the condition of the ED to decide whether this is high enough or not? So then there is this complex decision of whether to BIRT this patient or not. And here comes the operations research part of the project. The second tool will be based on our OR tools. Okay, so what we did when we first started with this is we had some data from UNC EDs from 2012. It's getting old, our data is getting old now. But so this data, uh, using this data, we just obtained a logistic regression model, and we estimate the hospital admission probability based on only information at triage, because that's what the nurse is going to have at that point. And we found that some of the predictive variables were like chief complaints, the severity score of the patient, the triage level of the patient, and age, for example. And so once you have that tool, then on top of that, what we did in the second part is a decision tool to decide who to BIRT and when to BIRT. And here we use a queuing control approach, which is really where my expertise is. And like I said before, we need to intuitively come up with a threshold on the hospital admission probability, but not just that, and we need to determine whether this threshold should be a constant throughout the day, or do we want it to depend on the state of the hospital, like when it's busy or not. So what we did is our general approach for developing the second tool, the OR tool, was we developed a simple mathematical model that captures the basic trade-off of this weighting versus making false calls. Well, we're looking at a simple mathematical model because we would like to analyze this in order to get a solution out of it. And we use the solution later on to extend it into a heuristic method that can actually be implemented in the real emergency department. And finally, we test the performance of this policy that we created using a realistic validated simulation, discrete event simulation model of the emergency department. Okay, so our simple queuing control problem looked like this. We now think of emergency department as a single bed ED. Of course, there can be like 70 or 100 beds at an ED, but for now, for this queuing model, we have just a single bed, and and then patients queue in front of the bed. So these little circles denote the patients. And then, so the decision is that for some of these patients, I can make the call early and start the bed preparation process, or I can leave it to the end, to the second stage. So the first one is parallel service when we BIRT. ED treatment and bed preparation happens in parallel. And then the second option is no BIRT, which is what is currently being done at all emergency departments, which is sequential service. So in one case, service time is shorter. In the other cases, service time is longer. So in order to make this decision solve this decision making problem, we formulated the problem as a Markov decision process. So for those of you who work on reinforcement learning, the idea is pretty similar. So we are solving a sequential decision making problem, making under some Markovian assumptions. But our goal is not to numerically solve it, rather theoretically analyze and get the structure of the optimal policy from this formulation. So I'm not going to get into details of the formulation, but what I want you to know at this point is in order to establish the trade-off between waiting times and the false calls, we introduced some cost parameters. So these CW, CAD, and CTR. So these are not dollar amounts. These just mean the penalty that the ED management would give to 1 unit of waiting of a patient versus making a false call to the hospital. So these are relative costs that can be adjusted. And then another thing that I would like you to take from this slide is, so here Z's will denote Z and alphas. I'm going to use them interchangeably to denote the probability of admission of the patient that's at the beginning of the queue that we're going to decide. Okay, so then our goal is to minimize the long run average cost in that case to balance these two costs associated with waiting and making false calls. Well, the first step is when you work with an MDP, Markov decision process, is to write down Bellman's equations or optimality equations. And then what we did is we don't numerically solve these, we analytically treat them to obtain the structure of the policy. For that simple single server queuing system, this is the policy structure that we can prove. I don't want you to read all this, so I'll just give you the nugget. So if our queuing system is stable, that's that condition over there, the first condition, then we can prove that there exists an optimal BIRTing policy that is of threshold type, which we expected, right? There should be some threshold on the admission probability. But it's not just on the admission probability. This says that there exists an integer capital N, which is a function of the admission probability alpha, such that if the number of people at the emergency department is above this capital N, so if the ED is sufficiently busy, then we're gonna make the call early. So it's saying that if the emergency room is busy, then we are more likely to make this call. And also this capital N, we can prove that is a non-increasing function of alpha, the admission probability, which means that the threshold drops if you have a patient that has a high probability of admission. So the optimal policy structure for the single bed simple queuing system says that if you have a busy ED and the probability of admission of this patient at the beginning of the queue is high, then we're going to BIRT. Otherwise, we are not going to make that call. Okay, well, our theorem doesn't give us an expression for what this threshold should be. So the first thing in order to implement this policy, we need to give the ED a threshold, right? What this capital N is. So in order to do that, we did one further simplification to our model, and we looked at the clearing version of the model. Clearing version in queuing theory means you ignore all the arrivals. So suppose at the ED you have 60 patients, then you just want to clear the 60 patients and ignore all the others that are going to come in the near future. So then the problem becomes a little bit easier, and we can actually obtain a threshold now, this threshold, on the number of people. So little n is the number of people at the emergency department, and the right-hand side is our threshold. So this threshold depends on the cost parameters, the service rate, and also the probability of admission of this patient. And this is in the case where we ignore the arrivals. I want to emphasize. Then we need to somehow incorporate the fact that there will be arrivals in the future. So what we did is we adjusted this threshold by using a result from queuing analysis, classic busy period analysis, and we replaced this n over up there, the number of customers at the ED, with the adjusted case where alphas there, lambdas there, sorry, denote the arrival rates. So we now incorporated the future arrivals into our threshold, and we came up with this threshold that is pretty easy to code in any electronic record system. So the final, well, this is still not enough. It's not in an implementable stage at the ED. There are many challenges, but one of the two is moving from a single bed. Of course, the ED is not a single bed ED, but there is this nice result in queuing theory that says that if you have a busy is a heavy traffic system, then multiple server systems act more like pooled single system. So then we decided, okay, if we think of this as a pooled multiple system, then this approximation will work fine. So we'll did that pooling approximation. The second thing is that emergency departments are highly non-stationary systems, meaning the arrival rate throughout the day will not be a constant. It's during the nighttime you expect fewer patients, and during the daytime, especially towards early afternoon, the arrival rate, just skyrockets. So, but our single server model was assuming stationary team. So we had to find a solution to this. And what we did is, our proposed approximation is, instead of using these lambdas and service rates as constants, we made them dependent on time. So it will change with respect to time. All right, then the final version of our BIRTing tool looked something like this. So again, I don't want you to read all of this. So here, capital N is the ED census, that's the number of patients in the ED, and Z is the hospital admission probability of the patient that goes through triage. So our tool says, so this Z thing is going to come from this prediction model, right? That the that we use in this case with logistic regression, then our tool will say, the BIRTing tool will say, if the number of patients at the ED is less than K, which is the number of beds, so meaning that we have empty beds at the ED, then this is the threshold that we're going to use on the admission probability. And it doesn't depend on the number of people now, because this means that the ED is not busy at this point. But if all the beds are full and it's greater than K, then we use this adjusted threshold on the admission probability. So these are, if you look at them, are very simple functions that can be really simply incorporated in the electronic record system. So if the triage nurse enters data about the patient, then our logistic regression tool will tell what Z is. And then the rest is going to be looking at the ED occupancy, the census at that point. Then we're going to have this threshold. And if this condition is satisfied, it will blink a red light and it will tell the nurse that, okay, here's a patient that we should do the early call. So they are not easy, they are very simple to implement. If you want to implement an even simpler policy, then what we can do is we can ignore the ED census, and we can just say that I'm going to BIRT everybody that has a probability of admission greater than 0.9, for example, right? So then this simple policy is an alternative, and it has this only parameter T, our threshold. So you need to somehow find a way to come up with this 0.9, 0.8 threshold. Okay, so then we have these two policies. What we did is we did a discrete event simulation study using our data. It took us really literally years and multiple students to come up with a model that we are really happy about, that we can validate. So what I mean is, so in the emergency department, the performance measure we really care about is the length of stay, this LOS thing. The green curve, which means it's the total time that a patient spends from the beginning until the end. So the time that they step into the ED, including the waiting time, until the time that they leave the ED. So we want this to be shorter. So then what you need to look at this is only the green curve on this plot, really. So the solid line is for the simulated curve, and the dashed one is for the from the real timestamps from 2012. So we really spend a lot of time to match these and made several changes in our discrete event simulation. But now that we have this simulation tool, we incorporated this BIRTing idea. So here are some results based on this 2012 data. So on this plot, the x-axis is this length of stay that we would like to shorten. And on the y-axis, we have the number of daily false BIRTs, false positives. We want both of them to be small. So a policy that is nice has a curve that is closer to the origin. Without the BIRT, within the current ED system, the length of stay is around 356 minutes, about around 4 hours. So we are at the end of this plot here. But if you implement one of these policies, fixed threshold or census-based threshold policies, then if you are okay with at most one daily false positive per day, then we are on this edge of the plot, right over here. And the two policies here are very similar, and the amount of reduction that we get is about 5 minutes per patient. So you may say, well, 5 minutes is short, but I want you to notice that this is for all the patients at the ED, not just for those whom we are calling ahead or who are admitted to the ED, but for everybody. Even if you go for a very little scratch or something, you're going to save 5 more minutes from your time on average. And also, if the management is willing to do more, willing to take more risk and then do more calls, which means more daily false positive, like around 3 on this part of the curve, then the two policies separate a little bit, and we get a saving of like around 10 minutes in this case out of 4 hours. And also to give you some idea about what this saving 10 minutes means is, it can mean 2 or 3 more patients that the ED can see per day. So it's not a very trivial thing, actually. This is I mean, another thing that we saw from this plot was that, well, these two policies are not too different. So maybe fixed threshold is good, which is simpler. Then we don't need to think about the ED census. But this was from a typical year. So this is a long run simulation. What if we look at a case where there's an extreme event, like an influenza epidemic, which may take place every 5 years or so, according to CDC. And we obtained some scenarios from CDC's Center for Disease Control, and then simulated the case where there is a 6-week influenza epidemic, and then we saw what happens. So in this case, these two curves for the fixed threshold and the other one really separated out, and we can see that now census-based census-based thresholds actually are more responsive to these unexpected changes in the load in the emergency department. Okay, so so I want to talk a little bit in the 2 minutes that I have. I'd like to talk about my current and research and what I'm going to be doing in the near future. One thing is about this project, we would like to predict not just the admission, but also the most suitable unit that the patient will end up at the hospital, whether it's cardiology or general ward. And another thing is, instead of making predictions per patient, what we can do is we can give a prediction to the hospital management that says, well, I'm expecting a total of 5 patients that are going to be boarded to the cardiology department in the next few hours. So they can plan ahead in an aggregate way rather than for per patient basis, which the hospital management actually would like better. So in other words, we would like to predict the ED load on the hospital for the near future, like in 2 hours or in a day, at most a day, in order to control their operations. So in general, what I'm interested in and what I feel like there is a great potential of marriage of these machine learning and operations research ideas is hospital level load prediction. So what I mean by that is a hospital in general can be depicted as in this picture. So there's several departments, ED and intensive care units and medical units and so on. And the patients flow through this network throughout their stay. And if we can predict like how much load this emergency department will push onto the intensive care unit, then or the medical unit floors, then the hospital can make these complex decisions, some of these complex decisions of scheduling or like here I say, expediting discharges. In the second portion, I list some of the controls that the hospitals do, reducing closing the hospital to outside transfers and so on in a more informed manner. So for the prediction part, we can use machine learning methods, and for the control part, we can use operations research methods. So I'm pretty excited about this research that I'll be working on in the next, I believe, 1 to 5 years. And we formed a really nice team at UNC. So the main person that proved the results and did the simulations was a former PhD student of mine, Wang Chen, who is now a postdoc at Harvard Medical School. And my main collaborator in the operations research field is Professor Serhan Zia from my department. And we recently added a machine learning expert to our team in order to improve, make the step from logistic regression to more advanced methods, is Yufang Liu from my department. And of course, we collaborated a lot with medical professionals. Abi Mehrotra is an ED doctor, and also he's in the management at the hospital. And nurses are very important here for operations improvements, and we worked heavily with the nurses. And finally, we worked with there's a company called Roundtable Analytics who provided us statistical expertise. Just one note, so Kenny Lapiano was a SAMSI postdoc several years ago who worked with me, and he really liked the ED operations idea. And this Roundtable Analytics company is developing emergency department simulation tools, and they sell it to hospitals in North Carolina and Florida. So he's a SAMSI alumni.
Okay, so let's do one quick question, and then we'll take a break. Okay. Well, let's stick with the mic, and then we'll take that one offline. Okay.
Just curious if you ended up putting any calendar inputs in there and what they did. People get hurt more on weekends or on the 4th of July or opening packages at Christmas.
Oh, yes. You know what? In Chapel Hill, Halloween is the worst. So they plan for Halloween days, and of course, like if there is summer heat wave and so on. Yeah.
All right, so let's take a break before our industry keynote. Let's thank the speaker again.